Bob, my question is, in a society with 40% that are obese or morbidly obese, why do we need to feed people in labor and delivery?
That seemed rhetorical.
So the first question is, I'm going to address it. It's going to go to Doctors Nelson and Sullivan. Chlorprocaine for subarachnoid block for external cephalic version.
We've considered this. I mean, it is one of the few ambulatory procedures you actually conduct on labor and delivery. However, I think some of the advantages that you would hope to glean in terms of early offset of sensory and motor blockade, primarily motor blockade, are probably diminished in terms of the need for monitoring the fetus. Most OBs feel they need to monitor the child for some duration that usually extends beyond what I think is this gap you're trying to exploit between a bupivacaine and a chlorprocaine technique. You know, it's a good choice, but I think mainly the benefits you may get in other realms like orthopedic surgery in an outpatient center aren't going to be the same here, where the patient's there no matter what for a while.
Kenneth, do you want to comment on that? Because you've given a talk on chlorprocaine for spinal anesthesia.
Yeah, it's one of my favorite subjects, but...
That's why I fed it to you.
Yeah.
Take it.
But I have nothing to add to what that has, no, seriously, in terms of external cephalic version. Completely agree with John and have nothing to add.
So the next question, I'm going to go back to John. So John, does Medicaid or insurance company reimburse for anesthesia for external cephalic version?
Well, reimbursement is a regional dynamic, and so I don't know if all the answers.
Do they do it in Chicago?
Yes.
How about California? Jennifer?
Yeah, actually they do.
How about North Carolina?
I honestly don't know. Is Robert here? Certainly, there's a neuraxial, if there's a neuraxial anesthetic place, then yeah, I believe so.
So here's a question I'm going to throw out to Jennifer. So let's assume postpartum tubals are urgent. Should we change anything? Should those now be E-cases when we put down the ASA physical status? And how should we manage this? Should we bring in people at night for a tubal? Because it is an urgent case, and let's bring more people in, and let's avoid the trauma in the ER, or that's going on in the OR, because this is urgent. We'll bump that ortho case.
Well, I will say we do them, probably not at midnight, but we definitely will do them after our night coverage has come on. I mean, it depends on the how everything's staffed, but I mean, it is, I would be in favor of making it an E-case.
So you do them at night?
We do, yeah.
Who here does tubals at night? Who here would not do a tubal at night? Come on, you don't have to be shy. Only one person would do it at night. It depends on what else is going on. Okay, fair enough.
You don't do them at BMIs over 35.
You don't do them in BMIs over 35 at night or at all? Okay, fair enough. Kenneth, John, you want to add anything to that?
Nothing.
Yeah, there's gray area in what we call night. We'll do them if we're a freestanding women's center, so we don't have the resources for us are different. But if we do have a gynecologic OR team in house, then we'll do them anytime. Sure.
So, Dr. Nelson, you generated 4 people's questions concerning the BMI of these Japanese. What was the BMI in this population that you referred to?
Low. Honestly, I don't remember. And in fact, I'm not sure he even reported.
Can you say it lower?
Low. I'm not sure. Well, actually, it'd be more like low. I don't know. I'm not sure he even reported it, honestly. That, to my recollection, but I do know that it was a typical Japanese population, as we all know. It's low.
So this one's for Dr. Sullivan. And somebody help me. Wait, can you read this for me? Because I'm not going to pronounce it correctly.
Moxibustion. Yeah.
Moxibustion.
Yeah.
Moxibustion for breech. See, thank you. You saved me because I would have just embarrassed myself.
There is a randomized controlled trial out there demonstrating a positive effect of moxibustion, which, if you don't know what that is, it is the burning of herbs, I don't know, near your toes or something That's some kind of modified acupuncture herbal technique. There is one randomized control trial, but as you also know, even if a disbeliever in some of these techniques and think that maybe 1 in 20 trials would end up positive just by chance, you'd fall into the skeptics group. 2 of my colleagues at Northwestern who had breech, who are obstetric anesthesiologists and breech as nullipris patients, got moxibustion and avoided version. They both turned with us. I think for the most part, my sense is that, I believe in acupuncture. It's really hard to imagine the mechanism by which burning herbs in proximity to one's body would cause a fetus to rotate in the uterus.
One's feet, more specifically.
I think we actually, maybe because it's San Francisco, but we definitely advocate for moxibustion. So.
What's the downside? That's the...
Yeah, so our patients will...
I would have guessed that. If I had to pick, I would have guessed our California colleagues would advocate for moxibustion, but and in Kentucky we don't. So, Jennifer, I should have followed up with Kenneth because someone else asked, when you're considering maternal BMI, do you refer to the pre-pregnancy BMI or the BMI at whatever gestation they are?
I think we look at both. So, because it's really the change. So, really, when we're talking, it depends on what we're talking about. When we present them and think about their issues of facing whatever, either surgical issues, if we're talking about accretas, if we're talking about C-sections, even delivery, we will talk about what their current BMI is, but it's always brought up what their pre-pregnancy BMI is. So it's really what matters right now.
So, Kenneth, this one's going to go right to your heart. They said that your talk convinced them to not do left uterine displacement, yet your conclusion was left uterine displacement. Can you please explain the oxymoron?
Yeah. Fair enough.
I just wanted to get that word in.
Yeah, I'm the oxymoron. I'll admit it. Right. So I can. Yeah. I'm Baloo. So the data cannot. The data support you if you want to abandon left uterine displacement. For the reasons I listed, though, and hopefully I made that clear, I'm not abandoning left uterine displacement, and those reasons are because we don't have good data for a lot of the patients that we're taking care of that may benefit from it in some way, and those are obese patients, preeclamptic patients, patients with other disease states, cases of fetal distress that are ongoing, and so forth. So I haven't abandoned it because there's little risk to it, and it really doesn't make that much difference. But what I have changed is that the second someone complains, be it the surgeon, be it me or my colleagues, or the patient about uterine displacement, and there is no other risk factor causing me to try to force it to happen, then I flatten them out and don't worry about it. So I think that's fine.
So the next question then goes to Dr. Sullivan. As president of the Society of Obstetric Anesthesia, how do you feel listening to an individual say you should deviate from the OB anesthesia guidelines as voted upon by the ASA?
I'm going to answer that question as a private citizen. My answer to the was this broadly speaking, or are we talking about Kenneth's?
Yeah, that was my. What guideline are we talking about?
Yeah, I was.
The guideline states you're supposed to do left uterine displacement. It's very clear.
Okay, just wanted to clarify that's what we're talking about. I would answer almost identically.
Although we could go to the eating one too. We'll save that one for next.
Well, I think two things. First of all, my answer with regard to the clinical practice is almost identical to Kenneth's, and that is that I do employ left uterine displacement routinely, but am not as militant about it as I used to be. As evidence is accumulated, I think this does affect a subset of patients in a certain amount, in a small amount of circumstances. The ASA guidelines are meant as guidelines, but not absolutes. We expect you, as practitioners, to occasionally deviate from them, but recognize that it is a body, these guidelines are built on a body of evidence-based literature, that if you have a very good reason to deviate, then you should, and that's expected. There's probably a little bit of medical legal risk when you do that, if some adverse event occurs that you should at least be aware of, but I think you need to deviate from clinical guidelines at times according to your judgment.
So Jennifer, I'm going to jump in on this. So in fairness, I didn't announce this, but Jennifer was also an obstetrician before she became an obstetric anesthesiologist. Jennifer, how annoying is it to operate for a cesarean delivery with left uterine displacement?
It's actually really annoying.
Is it? I mean,
It is.
seriously, really?
No, it is. I mean, not to mention that you get splashed a lot more. You learn that you better wear the long booties when you're a chief resident because you will get splashed. And it is, that's why the first thing once the baby's out, level the table because it is challenging. We get used to it. Of course, once I came onto the other side of the drape, and I was like, we need to do left uterine displacement. But I do the same thing where I will, if it's challenging, it just depends on the patient's habitus. Sometimes, I mean, they're literally practically falling off the bed. It doesn't make any sense. And so I probably won't completely level it, to be honest, but I reduce it a little bit.
And also keep in mind that Jennifer has probably almost never operated at 15 degrees lateral tilt.
So, and then I'm going to now deviate. I'm going to ask Dr. Sullivan a question. So, on a scale of 1 to 10, what is the obstetrician whine factor that would make you choose to do left uterine displacement? Because you said you have to have a reason for deviating from a guideline.
What am I, a 0 to 10 on a whine factor?
I can't operate.
I think it's gone pretty low lately.
So you'll go down to a 1?
I was thinking 2 as the number was coming to my head, but a practice that developed at my institution was that there was routinely, the group was asking to flatten the bed prior to delivering the baby, which I was fighting at times, but at some point it seemed like everyone was adopting this. It seemed like that was the worst time to do it. You're about to transition this child in this vulnerable state. Why are we doing it now? I think it's just one of those battles that I chose not to fight. I don't feel that strongly about it like I used to, based on some of the data we've seen.
And now the question I'm going to throw out to the group. So we have a term healthy parturian who's laboring with an epidural. Everything's going smooth. She has no coexisting disease. She's not obese. Who requests to have a small snack of crackers or toast. Would you allow it? So I just go down the group. So we can start. We'll start with Jennifer because we'll do ladies first. And then we'll take John because he's the president in deference to him. And then we'll do Kenneth, who's our Baloo.
What's her cervical exam?
Why do you ask? I'm an oral examiner. I'm not here to answer them. You are.
So I think if someone wants a little light snack and they're really not in active labor, I mean, one would argue maybe they were anxious and wanted that epidural early because they were worried about having pain. Probably let them have a little bit of a cracker, but I would give them a full disclosure of the risks that they're taking.
So I'm going to change it. Multip, 8 centimeters. She's delivered once before. She has an epidural, so she's comfortable, and she wants a light snack.
I'm going to give her the protein shake.
So you would not allow them to have the light snack?
No, I mean, I think I mean, we have this discussion all the time, and again, I'm not kidding when my least favorite thing to hear at rounds is the patient's going to get an epidural, but right now she's having her breakfast, and her breakfast is not a protein shake. It's like, eggs and bacon, and I kind of roll my eyes and say, really, guys, So if they're asking me, I'm going to say no. If it happens and I don't, which it often does happen when I'm not there or they don't ask me, then I mean, not a whole lot I can do about it.
Okay. Dr. Sullivan?
I think, the same, it's hard to justify. The absolute risk of aspiration is fairly low, but it is unpredictable often the circumstances that you find yourself in these emergent deliveries. The absolute risk is low, and my perception of the satisfaction benefit from this is incremental and often based on incomplete information on the patient's side. We allow ice chips and clear liquids, but it's hard to argue that, a boost in glucose can't be achieved with something that's not a clear liquid. It's just hard to convince me that that's worth that benefit. And again, I've never been in labor.
Yeah, we honestly don't struggle with this that much at Wake Forest because we have for whatever reason, it's just the culture. We have very conservative guidelines that are very clear. Anyone at high risk has an earlier cutoff. All are cut off at 6 centimeters. And I think what happens, everyone's on board with it. Labor nurses, obstetricians, of course us, maybe not the patients under certain circumstances, but I rarely hear anything from patients complaining about not having solid foods while they're in advanced labor. So it's really not an issue. And my answer would be no, she would not get crackers.
So now I'm going to turn it to the audience. So you're going to raise your hand and you're going to keep it up as we go along. So we have a multiparous woman who's delivered vaginally before, who is now 8 centimeters. She has an epidural in it and is very comfortable. Who here would allow ice chips? So keep your hand up if you would allow clear fluids. Keep your hand up if you would allow like Jell-O. Who here would continue if you would allow ice pops? And now crackers. I still see a couple of hands up, so we'll keep going. So we'll see if we can get them down. So we got toast. All right, we got the toast. All right, we got the. Come on, you didn't get me to. I was all set to go. I'm now from the day. I was going to do shrimp and grits.
Yeah.
Yeah, shrimp and grits. We got it. All right, with that, please join me in giving a round of applause to our panelists.